Welcome to the St Emlyn's podcast. I'm Ian Beardsall, and this is another episode recorded live at the Premier Conference held in Winchester in June 2024. In this episode, Dr. Tim Warlow, a consultant in Paediatric Palliative Care, gives his top tips on how we can best look after children with life-limiting illness or nearing the end of their lives who need care from the emergency department. Tim talks about just what we mean by palliative care and suggests 10 top tips to guide you to do the best you can for these patients and their families and carers. Thanks again for listening to the St Emlyn's podcast. Don't forget we have a library of over 250 episodes on a wide range of topics that you can explore wherever you get your podcasts. And as always, don't forget to like and subscribe. With that, I'll now hand you over to Tim and his excellent talk. There's a comprehensive blog post to accompany this podcast on the website, and I hope you find this talk as useful as I did.
So I'm a consultant in children's palliative care at Southampton and Naomi House and Jack's Place. I cover the whole of Wessex, homes, hospices, wherever the child is. And I'm here to talk to you a little bit about how we look after these children in the emergency department. This is the definition of palliative care. It's quite wordy and quite long. And I think that's what many people struggle with, is knowing what is palliative care. And I think the key points from this, it's an active approach. Often the care increases at a time when palliation is mentioned, not decreases. Palliative care services get involved from the point of diagnosis of a life-limiting condition. So that's either a condition that's palliative from the start or a situation where a stable condition is seen to be deteriorating in a child, for example, cerebral palsy, and the child gets repeated chest infections or gut failure. And our main role is to enhance quality of life, so to get the best out of each day for that child and family. And every time I speak to anyone outside of medicine about my role, if they don't cry immediately, they often tell me how sad it must be and how awful each day must be working in this specialty. Sometimes I sort of say, keep the sympathy coming. But actually we have a lot of fun, and our role is to have fun as well as do paediatrics, the same as for you guys. Why the focus on children's palliative care? The numbers of children with life-limiting conditions are increasing over recent years. You'll probably see that in your emergency departments. From 2021 to 2017, the prevalence has increased from 27 to 67 per 10,000. And taking those numbers forward, for Hampshire, we can see that there's around 3,000 children in Hampshire Isle of Wight with life-limiting conditions at the moment, but that's likely to increase to nearly 4,000 by the end of this decade. That's an increase of 27% in that short time. So what are the implications for ED? So as well as the increased number of children with life-limiting conditions, we're also seeing increased medical complexity. More children are technology dependent. I've got a number of children in the community at the moment who've got high dependency level care in their homes with 24/7 nursing. So they come to the emergency department, and even being able to maintain that, let alone think about escalation, is a real challenge. This has all occurred at a time where parental expectation has changed. Alongside that, post-COVID, community services have really struggled to recover after COVID, with particularly community nursing numbers. And at the moment, we're still not in a position where we have 24/7 specialist palliative care advice. What does that mean for you guys? Well, there's not a lot of literature on life-limiting conditions attending ED, but what we can see in terms of admissions to PICU is that those with life-limiting conditions make up 58% of PICU admissions and 72% of PICU bed days, and that was in 2018. Based on a study across the UK. So how can palliative care help you? What is it we're trying to do to make things better? So we're working really hard with the integrated care boards to achieve commissioned 24/7 palliative care. We're doing a lot of training and education across the region on how to talk to families about difficult things before they get to the emergency department. We're working on a commissioned palliative care service across the region, and also things like a digital platform to be able to share advanced care plans. So actually when a child comes into the ED, you're not having to fumble around trying to find where an advanced care plan might be to talk about those discussions. One of the biggest changes we've seen recently is a new version of the advanced care plan. And this has come as a standard form now with respect, and an antenatal version with respect. So babies in the community with life-limiting conditions will have an antenatal version. And we've got a number of children with Edwards and Patau's in the area as an example. So one of the things I was asked to do was to give some top tips of how to manage a child in the emergency department. So these are my top tips. And I did this in conjunction with a family of a child with cerebral palsy who was a couple of days away from the end of life at the hospice. So we kind of worked on it together. And the first thing would be to recognise the child with a life-limiting condition. And this is really difficult. People have tried to list all the life-limiting conditions. There's over 400 that people have worked out, and a load of conditions that are undiagnosed. So the question to ask yourself is to step back and think, Would I be surprised if this baby, child, or young person died before reaching adulthood? And if the answer is no, then it may be this child's got some palliative care needs. Second of all, listen to the family. And I don't mean that in the same sense as you all do so well already. I've got children that I look after whose body temperature normally is 33.5, whose resting heart rate is 32 to 35, and who sometimes breathe and sometimes don't breathe. But they've managed to do that for a lot of years. These children write their own story, and they're completely on their own. And parents and carers know them inside out. So listen to them even if it doesn't make sense. Also, the medications they're on are often a combination of trials of this and that over multiple years. And again, it may not make a huge amount of sense in some ways. And it might not help you to find out medically what's going on in that moment. But these families might attend ED, as you know, for lots of more reasons than just the medical ones. Number 3 is to build rapid rapport. Now, why do you need to do this, particularly with this group? The fact is that this population of children, they can be fine 1 minute and then really not fine the next. And you don't know what sort of depth of conversation you're going to have 20 minutes from now. So it's worth often going deep and going deep quickly with these families. And they're used to it. They're used to difficult conversations. One of the really important things for families is that we speak to the child who's non-verbal before the parents. Take time to summarize and clarify what's going on, why they've actually attended the unit, because often there's so many different reasons. Acknowledgement is one of the tools that I find most effective for going deep with a family really quickly. If I've got a child in PICU and I've only just met them and within an hour they've got to go to the hospice for end of life, really acknowledging how crap this situation is right now is a huge win in terms of gaining trust and really helping the family to relax and to develop that sense of trust. Take time to ask what the child is like when they're well. So often families worry that we only see their children when they're sick and we judge their quality of life on the basis of what they're like in hospital. So take time to have a look at some photos, have a look at their All About Me documents that are designed to help you guys make the best decisions for their child when you see them in the emergency department. If possible, try and accommodate the sensory and environmental needs as best you can, but I appreciate that's a challenge. Number 4 is read the advanced care plan if it's present and confirm with the family. These families don't want to go over the whole story again, and if they've written it and gone through it, have a look at that first, check that it's up to date. That will win you credibility in the discussions. One of the challenges is finding the advanced care plan and making sure the one you've got is up to date, and that is a challenge. Parents and families are the best port of call. Also, SCAS, or the ambulance service where you are, will have the latest version. Beware of unconscious prejudice. Sometimes the word palliative can be a barrier for children receiving investigations or treatment that might be the right thing to do. And also sometimes we can look at a child and think to ourselves, there's no way that I would want that life. And that can sometimes find its way unconsciously into us thinking that we shouldn't escalate for this child when it might be the right thing to do. Sometimes I wouldn't want this life can make us feel like this isn't a life worth living. The child's quality of life must be poor, and therefore we shouldn't escalate. So just have that in the back of your minds. The way I try and think about it is to take a step back and thinking, am I making this decision based on this child's disability or diagnosis, or on the benefits and harms of this intervention at this particular time? Be honest about the possible outcomes, even if it's hard. The families will have already had those thoughts ahead of you. Explain your rationale for should decisions. We sometimes think it's not going to be right to escalate for this child, and that's completely valid, but take time to explain why. Explain the benefits, the harms or risks, the magnitude of those, and the likelihood of those. And families really value that, because they come into A&E thinking these people are going to judge the value of my child's life based on their disability. So our job is to disprove that hypothesis. Avoid these phrases. Okay, these are the top phrases families really struggle with. The care that we might withdraw is life-sustaining treatment, not treatment itself. Often, as I've said, treatment gets more intense as palliative care becomes involved. And these are some of the phrases families really struggle with. They're worried that when there's no cure, people are going to abandon them. They're going to feel alone. And that can sometimes drive them to make decisions that are perhaps not in the best interest of their child. Don't be afraid to be yourself. Take time, collect yourself before you go in and see them, and try and be truly present with them. They will notice. They will have seen hundreds of doctors in emergency departments before. It's okay to be sad. It's okay to laugh. But it's hard, so get some support. And lastly, when all else fails, if this is a situation that's going totally wrong in front of you, just be there. Okay, that's the most important thing. Be there, and actually your presence with them is far more important than what you can do or choose to do to their child. Thank you very much.